2:14 in the morning. Gerald's apartment is dark and still. He is 61 years old, retired electrician, solid build, not a man who complains. He has been sleeping on his left side the way he always does, and then it hits. Not the dull ache he has felt on and off for months, the one he chalked up to stress, to getting older, to the weather. This is different. This is a crushing weight behind his breastbone, like someone parked a car on his chest. His breath catches. His skin goes cold. His wife wakes up, sees his face, and calls 911 without asking a single question. In the emergency room, the cardiac surgeon tells him his coronary artery is severely inflamed. The inner lining is shredded. A clot has formed at the damaged site, and blood flow to part of his heart has nearly stopped. They need to operate immediately. Gerald survives. 3 days later, the cardiologist sits down beside his hospital bed and asks a question that changes everything. What medications do you take every day? Gerald lists the usual: blood pressure pill, a statin for cholesterol. Then he mentions the one thing he never thought twice about, the thing he bought over the counter at a drugstore. No prescription, no doctor involved, no warning. He took it every single day for the last 4 years because his knees hurt and it made the pain go away. That pill did not protect Gerald. It nearly killed him. And there is a very good chance you have a bottle of it sitting in your medicine cabinet right now. The drug class is called NSAIDs, non-steroidal anti-inflammatory drugs. You know them by their store names: ibuprofen, Advil, Motrin, naproxen, sold as Aleve, diclofenac, available as Voltaren. They sit on open shelves in every pharmacy, every grocery store, every gas station in the country. No prescription required. No conversation with a doctor. You pick up a bottle the way you pick up toothpaste. Over 100 million Americans use NSAIDs regularly. Many take them daily. Many have been taking them for years. And most of those people have never received a single clear warning about what these drugs do to the cardiovascular system. The fine print on the box mentions heart risk in small text that nobody reads. The pharmacist does not bring it up. The cashier certainly does not. Here is the part that makes this so dangerous. These drugs work. They genuinely reduce inflammation in your joints, your muscles, your tendons. That is exactly why people trust them. Your knee hurts. You take one, the pain eases, and you think you found a simple, harmless solution. But what most people do not know, and what nobody at the pharmacy counter explains, is that while NSAIDs are suppressing inflammation in one place, they are triggering a completely different and far more dangerous inflammatory process somewhere else, inside your arteries, the very blood vessels that feed your heart and your brain. That is the paradox Gerald never saw coming. He was treating one kind of inflammation while silently fueling another, and by the time his body finally sent the signal loud enough to notice, he was on an operating table at 2 in the morning. To understand what happened to Gerald, you need to understand one structure inside your body that almost nobody talks about. It is called the endothelium. Think of it as a coating on the inside of every artery you have. It is one cell thick, one single layer of cells lining the entire inner surface of your blood vessels, from the arteries feeding your heart all the way down to the smallest vessels in your fingertips. When that lining is healthy, it works like the coating on a brand new nonstick pan. Blood flows past it smoothly. Nothing sticks. Nothing clumps. Nothing builds up on the wall. Cholesterol particles float by without grabbing hold. Platelets pass through without clotting. The surface is slick, smooth, and completely intact. Now picture what happens when you scratch that non-stick coating. The surface becomes rough, uneven, sticky. Everything that used to glide past now starts clinging. That is exactly what happens when the endothelium becomes inflamed. The cells swell, gaps open between them. The wall becomes permeable. White blood cells burrow into the damaged area. Cholesterol particles lodge in the rough patches and refuse to leave. Inflammatory proteins pile on top. Over time, those deposits grow into plaques. The same plaques that narrow arteries, restrict blood flow, and eventually rupture. Most people assume this process takes decades, and it can. But when something is actively attacking that lining every single day, pouring chemical damage onto the endothelium with every dose, the timeline compresses dramatically. Damage that might have taken 20 years unfolds in 4 or 5. Something was poisoning Gerald's endothelium every single morning for 4 years. He swallowed it with a glass of water right alongside his blood pressure pill, and he had no idea. Here is exactly what NSAIDs do inside your blood vessels. And once you understand this, you will never look at that pill bottle the same way again. NSAIDs work by blocking an enzyme called COX-2. That is how they reduce pain and swelling. COX-2 drives inflammation in your joints, so shutting it down makes your knees feel better, your back loosen up, your shoulders stop aching. That part works exactly as advertised. But COX-2 does something else that the label does not mention. It produces a substance called prostacyclin. Prostacyclin is one of your body's primary tools for keeping blood vessel walls relaxed and flexible. It also prevents platelets, the tiny blood cells responsible for clotting, from clumping together. When you block COX-2 with a daily NSAID, you do not just block the pain, you block prostacyclin production. Your arteries lose their ability to relax, your blood becomes stickier and more prone to clotting. That is mechanism number 1. Mechanism number 2. NSAIDs cause your body to retain sodium and water. More fluid in the system means higher blood pressure. And chronically elevated blood pressure is one of the most direct and well-documented causes of endothelial damage. Every point your pressure rises, the physical force on that one-cell thick lining increases. Mechanism number 3. NSAIDs make the endothelium itself more vulnerable to oxidative stress. The cells that form that protective coating lose their ability to repair and defend themselves. The lining weakens, gaps open, inflammation moves in. Now put all three together. Gerald was swallowing a pill every morning that was simultaneously stiffening his arteries, making his blood more likely to clot, raising his blood pressure, and stripping away the protective lining of his vessel walls, every single day, for 4 years. And the entire time he believed he was simply managing a bad knee. Here is what should bother you. Most people taking daily NSAIDs have never had a single conversation with a physician about cardiovascular risk. Not one. They walked into a drugstore, picked a bottle off an open shelf, read the word anti-inflammatory, and thought that sounded like a good thing. Nobody stopped them. Nobody asked how long they planned to take it. Nobody mentioned their heart. In 2015, the FDA strengthened its warning on every NSAID on the market. The updated language states clearly that these drugs increase the risk of heart attack and stroke, and that this risk can begin within the first weeks of regular use, not years, weeks. The warning also states that the risk increases the longer you take them and the higher the dose, and it specifically flags people over 50 and anyone with existing heart disease or risk factors. That was over 10 years ago, and yet every single day, millions of people swallow these pills with no idea that warning exists. So the question you should be asking right now is simple. What do I actually do with this information? Most people will watch this, feel concerned, and do absolutely nothing. They will go back to their evening, but you do not have to be most people. If you have been taking NSAIDs regularly, or if you have any of the risk factors we just discussed, high blood pressure, a history of smoking, elevated cholesterol, or a family history of heart disease, there is a practical step you can take right now. Care Health is a free platform that connects you with cardiac screenings, blood pressure monitoring programs, and clinical trials for heart disease and arterial health in your area. You fill in a short form, your date of birth, gender, whether you have children under 18. It takes about 30 seconds, costs nothing, and requires no commitment. Care Health matches you with relevant options near you. Click the link in the description below this video, or if you see the QR code on screen, open your phone camera and point it at your screen. Now, back to what you need to know. Because the NSAID problem goes deeper than most people realize. NSAIDs are not equally dangerous for everyone. There are specific groups where the risk jumps sharply, and if you fall into any of them, what I am about to say deserves your full attention. The first group is anyone over 50. After 5 decades of use, your endothelium is already less resilient than it was at 30. The cells repair more slowly, the lining is thinner. Adding a daily chemical insult on top of an already aging vascular system does not just add risk, it multiplies it. The same dose your body tolerated at 40 hits significantly harder at 60. The second group is people with existing high blood pressure. We covered how NSAIDs cause your body to retain sodium and water. If your blood pressure is already elevated, NSAIDs push it higher. But there is another layer most people never hear about. NSAIDs actively blunt the effectiveness of blood pressure medications. Your doctor prescribes a drug to bring your numbers down. You take an ibuprofen every morning for your back. The ibuprofen partially cancels what the blood pressure pill is trying to do. Your readings stay elevated, and nobody can figure out why. The third group is people taking low-dose aspirin for heart protection. This one is particularly cruel. Your cardiologist prescribed aspirin specifically to keep your platelets from clumping and forming dangerous clots. NSAIDs can block that exact mechanism. The aspirin you are taking to protect your heart gets neutralized by the ibuprofen you are taking for your knee. The fourth group is anyone with early-stage kidney decline, a condition that is extremely common after 60 and frequently undiagnosed. NSAIDs constrict blood flow to the kidneys and can push borderline function into real, measurable damage. Gerald checked 3 of those 4 boxes. He was 61, he had elevated blood pressure, he was on low-dose aspirin, and not a single person connected those dots until he was lying on an operating table at 2 in the morning. Your arteries do not scream, they whisper. And if you do not know what to listen for, you will miss every signal until the night your body stops whispering and starts shouting. The first signal is blood pressure that has crept up over the past year without a clear explanation. You have not gained significant weight, you have not changed your diet dramatically, but your numbers are climbing. If you are taking daily NSAIDs during that same period, that is not a coincidence. That is your vascular system telling you it is under strain. The second signal is new or worsening shortness of breath on exertion. You climb a flight of stairs you have climbed 1,000 times and you need to stop at the top to catch your breath. You walk uphill and your chest feels tight in a way that does not match your fitness level. That is not simply being out of shape. That can be a heart working harder because the arteries feeding it are narrower and stiffer than they were a year ago. The third signal is fatigue that sleep does not fix. You get 7 or 8 hours and wake up heavy, drained, as though your body spent the night working instead of resting. Chronic arterial inflammation forces your cardiovascular system into a constant low-grade state of stress that burns energy even while you are lying still. The fourth signal is swelling in the ankles or lower legs by evening, fluid pooling where it should not. The fifth signal is chest tightness or pressure that appears with physical effort and fades when you stop. That pattern, exertion triggers it and rest relieves it, is one of the most classic indicators of compromised blood flow to the heart. No single one of these is definitive on its own, but when they appear in someone who has been swallowing NSAIDs every day, they are not random. They are signals from a vascular system that is under chemical assault. And here is the part that should concern you most. The absence of dramatic symptoms does not mean the absence of damage. Gerald felt nothing, no chest pain, no breathlessness, no warning he could point to, until the night his coronary artery gave out entirely. Right now you might be thinking exactly what Gerald wishes he had thought 4 years ago. Fine, I will throw the bottle out tonight. And that instinct is correct. But stopping the pill is only half the answer, and if you treat it as the whole answer, you will end up right back where you started. The first reason is straightforward. The damage already done does not reverse itself the moment you put the bottle down. If NSAIDs have been attacking your endothelium for months or years, that lining does not heal overnight. Plaques that have formed do not dissolve because you stopped adding fuel. Changes in blood clotting dynamics do not reset with your last dose. The vessel walls that have stiffened do not suddenly regain their elasticity. That existing damage needs to be assessed. It needs to be monitored. In some cases, it needs to be actively managed with the help of a physician who knows what to look for. The second reason is the one that traps most people. The pain that drove you to NSAIDs in the first place is still there. Your knee still aches. Your lower back still locks up. Your shoulder still burns when you reach overhead. If you remove the drug without addressing the underlying cause of that pain, whether it is arthritis, joint degeneration, a disc problem, or chronic inflammation from another source, one of 2 things will happen. Either you go back to the NSAIDs within a week because the pain is unbearable, or you white-knuckle through the misery and your quality of life collapses. Neither outcome is acceptable. This is the trap millions of people are caught in right now. They sense that the pill might be hurting them, but the pain without it feels worse. So they keep swallowing it day after day, because nobody has shown them a real alternative. That is exactly what we need to talk about next. The goal is not to trade pain for heart disease. The goal is to manage the pain without poisoning the system that keeps you alive. And there are ways to do that. Real, evidence-based approaches that address why your joints hurt, not just how to silence them for a few hours. The first and most important one is movement. That sounds counterintuitive when your knees ache. But here is the physiology. Cartilage has no blood supply of its own. It gets its nutrition exclusively through loading and unloading, the physical act of compressing and releasing the joint. When you move, synovial fluid gets pushed into the cartilage and delivers the nutrients it needs to stay intact. When you stop moving because it hurts, the cartilage starves, it thins, it breaks down faster. Targeted exercise does something else that matters enormously. Strengthening the muscles around a joint reduces the mechanical load on the joint itself. Your muscles absorb force that would otherwise grind through damaged cartilage. A stronger quadricep means a less stressed knee. That is not theory. That is biomechanics. The second approach is topical anti-inflammatories, gels and creams that deliver the drug directly to the joint through the skin. The critical difference is absorption. When you swallow a pill, the drug enters your bloodstream and circulates through your entire body, including every artery you have. When you apply a gel to your knee, the drug concentrates locally at the joint with dramatically less systemic exposure. Your endothelium barely sees it. The third is omega-3 fatty acids in therapeutic doses. Clinical evidence shows that omega-3s reduce systemic inflammation markers, including C-reactive protein, which we will talk about in a moment. This is not a miracle cure. It is a measurable reduction in the inflammatory environment that drives both joint pain and arterial damage. The fourth is weight management. This is pure physics. Every single pound of excess body weight places roughly 4 pounds of additional force on the knee joint. Lose 10 pounds and your knees experience 40 fewer pounds of impact with every step. No pill on earth delivers that kind of mechanical relief, and there are conversations worth having with your doctor. Whether acetaminophen, which does not carry the same cardiovascular risk profile as NSAID, is appropriate for your specific type of pain, whether a referral to a pain specialist or a rheumatologist makes sense. These are questions to ask, not prescriptions to follow from a video. Your situation is specific to you, but walking into that appointment knowing what to ask changes the entire conversation. When you go in for a routine checkup, your doctor orders blood work, cholesterol, glucose, basic metabolic panel. You get your results, everything falls within normal range, and you walk out thinking your cardiovascular system is fine. It might not be, because none of those standard tests measure the one thing that nearly killed Gerald: vascular inflammation. You can have textbook perfect cholesterol and a dangerously inflamed endothelium. You can have normal glucose and arteries that are already scarred, roughened, and accumulating plaque. The standard panel does not see that. It was never designed to. There is a test that does. It is called high-sensitivity C-reactive protein, or hs-CRP. C-reactive protein is a molecule your liver produces in response to inflammation anywhere in your body. The high-sensitivity version of the test is calibrated to detect even small elevations, the kind that signal chronic, low-grade vascular inflammation long before an artery fails. The numbers are straightforward. Under 1 milligram per liter is low cardiovascular risk. Between 1 and 3 is moderate. Above 3 is high and warrants serious attention. Above 3 means your body is running a level of systemic inflammation that actively promotes plaque growth, endothelial damage, and clot formation. It is a simple blood draw. It is inexpensive, and it is something you can specifically ask your doctor to add to your next panel. Most doctors will order it without hesitation if you request it. The problem is that most patients never know to ask. Here is what stays with me about Gerald. If anyone had ordered an hs-CRP test at any point during those 4 years of daily ibuprofen use, the number would have told the entire story. It would have shown that his arteries were inflamed, that his endothelium was under assault, that the quiet damage was building toward a crisis. One blood draw, one number, and the surgery at 2 in the morning might never have happened. Gerald survived. That is the first thing worth saying. He survived a surgery that many people do not, but survival was not the end of his story. It was the beginning of a completely different one. His cardiologist took him off NSAIDs permanently. No negotiation, no tapering, no exceptions. He was started on appropriate blood pressure management, the kind that actually works when it is not being sabotaged by a daily ibuprofen. He began a supervised walking program, short distances at first, building gradually, with a physical therapist monitoring his joints and his cardiovascular response. For his knees, he switched to a topical anti-inflammatory gel applied directly to the joint, and he started targeted strengthening exercises for the muscles around the knee. 6 months later, his hs-CRP had dropped from above 4 to 1.2. His blood pressure had stabilized. His cardiologist told him the endothelial damage was no longer progressing. His knees still ache on cold mornings. He still feels stiffness when he first gets out of bed, but he manages it without swallowing a pill that was quietly shredding the inside of his arteries. Gerald got a second chance. Most people who end up on that operating table at 2 in the morning do not get one. Now let me be direct about the takeaway, because I do not want you to leave this video thinking NSAIDs are evil. They are not. They are powerful, effective drugs with a legitimate place in short-term pain management. A few days after a dental procedure, a week after a muscle strain. Used briefly and intentionally, they do exactly what they are supposed to do. But they were never designed to be taken daily for months or years without medical supervision. The over-the-counter label makes people treat them like vitamins. They are not vitamins. They are pharmaceuticals with serious cardiovascular consequences, and after 50, when your endothelium is already less resilient, those consequences accelerate with every dose. If you are taking one every day, that is a conversation you need to have with a doctor, not next month, not at your annual checkup. Now, here is exactly what to do after this video. 1. Go to your medicine cabinet tonight. If you have been taking ibuprofen, naproxen, or diclofenac daily or near daily for more than 2 weeks, recognize what that means. Your cardiovascular risk has been elevated without your knowledge. That is not a reason to panic. It is a reason to act. 2. Do not throw the bottle out and call it solved. Schedule a conversation with your doctor about alternatives. Ask specifically about the condition of your heart and your kidney function. Tell them how long you have been taking the drug, how often, and at what dose. Give them the full picture so they can give you a real plan. 3. Ask for an hs-CRP blood test at your next visit. If your doctor does not suggest it, request it by name. High sensitivity C-reactive protein. It is the single best window into whether your arteries are inflamed right now. 1 blood draw. 1 number. It tells you what your standard cholesterol panel cannot. 4. If you have noticed any of the warning signs we discussed, blood pressure creeping up, shortness of breath on stairs, unexplained fatigue, swelling in your lower legs, chest tightness with exertion, do not wait for the next available appointment. Seek evaluation promptly. Those symptoms in someone taking daily NSAIDs are not minor complaints. They are signals from a vascular system under stress. Everything in this video is for your understanding and education. Your situation is specific to you, and a real conversation with your doctor will always be more valuable than anything you watch on a screen. But walking into that conversation knowing what to ask, that changes everything. And remember, that free cardiac screening link is in the description. 30 seconds could change the direction of your health. Take care of yourself.